Good morning, everyone. My name is Nguyễn Liu Li, MC for today's conference. Furthermore, I would like to extend the warm greeting from Vietnam University Hospital and Vietnam Association for Surgery and Endolaparous Surgery to the colleagues of Kaohsiung Veteran General Hospital, our external partner in this event. We are truly honored and excited to welcome you on to the international video conference on sharing experience on Eras implementations. Allow me to introduce the distinguished colleagues to join our video conference. Please welcome Nursing Department representative. Anyway. Thế rồi. Xong rồi cháu có phải giới thiệu nhiều người nữa không ạ? The VDUS office representative. And other doctors and nurses from other departments in Vietnam University Hospital, from Vietnam Association for Surgery and Endolaparous Surgery we have today, Associate Professor Nguyễn Đức Tiến, General Secretary, Advisor of Emergency Abdominal Surgery Department of Vietnam University Hospital, Associate Professor Nguyễn Đức Chính, President of Eras of Vietnam, Advisor of Septic Surgery of Vietnam University Hospital. From Kaohsiung Veteran General Hospital, let me introduce Dr. Chen Yuxun, Surgeon on Color Surgery. Dr. Chen Yanjiang, Surgeon on Thoracic Surgery. Miss Wang Ruhui, Head Nurse. At Vietnam side, there are Dr. Lê Quan Anh Tuấn from University Medical Center, Ho Chi Minh City. Dr. Vũ Hoài Anh from Huế Center Hospital. Now, my pleasure to invite Associate Professor Nguyễn Đức Chính to deliver the welcoming speech.
So, good morning, everyone. Thank you so much for accepting our invitation to join. You know, it's the first video conference that happened between two countries, especially for two hospitals, Vietnam University Hospital and Kaohsiung Veteran General Hospital as well. I think the MOU have been signed both sides, so we had many supporters from Kaohsiung Veteran General Hospital. Also another Veteran General Hospital in Taipei and Taichung as well. And we had many activity and support to improvement about patient care quality. So today we are so happy to hold on the first video conference on the topic. All the people are very interested on it, the Eras implementation. As you know, Eras Association under Vietnam Association for Surgery and Endolaparous Surgery that established it from last year. Until right now, we want to improve about patient care quality, especially focus on Eras implementation as well. So I think that today is a very good chance for all of us to share experience, how you can implement it effectively. Also to improve about the relationship, also the quality of care of the patient, both sides, especially for surgical patients as well. So today we are so happy for all the speakers from country that from Taipei, from the Veteran General Hospital of Kaohsiung, also Ho Chi Minh City, some very specialized, you know, the doctor, and also from West Central Hospital, one very big hospital in our own country. So today, hopefully, from this topic, we will the sharing experience. You can have also that very good, the chance to join also for improvement for the further cooperation as well. So again, thank you very much for all your kind contribution for to take today meeting conference that possible, and hopefully the success of the conference. Thank you very much, and have a good day ahead. Thank you.
Thank you, Associate Professor Nguyễn Đức Chính. Next, I would like to invite a representative from Cao雄Veteran General Hospital to deliver the opening remarks.
Good morning, everybody. I'm the Chief Associate of the Department of Nursing. After the COVID-19 pandemic, we can hold on this online I say it's a seminar because we not just share our experience, we want to have discussion. So I say it's a seminar. So we can hold on this online seminar with the Veteran Hospital again. It's very happy. Our hospital performs Eras successful on colorectal surgery and chest surgery. So today we have the two visiting doctor and trainers will share about the Eras experience, and we were discussing. So we look forward to discussing about this issue together during this seminar. Finally, we wish this seminar was successful, and thank you.
Thank you, Ms. Zhou Xuezhi. For the first present. For the first presentation, I would like to invite Dr. Chen Yuxun. His topic is on Eras for colon surgery.
We need to change the schedule because we will first be Dr. Zeng Yanqiang.
Good morning, ladies and gentlemen. My name is Yanqiang Zeng from Kaohsiung Veterans General Hospital, and it's my great honor to be the representative to introduce about the enhanced recovery after surgery Eras protocol for thoracic surgery in our hospital. As we know, we could divide the Eras protocol into three main parts. The first is the preoperative part, the second is the intraoperative part, and the third is the postoperative part. About the preoperative part or the postoperative part, in our hospital, we have already standardized about the Eras protocol. As a surgeon, we would like to improve our surgical intervention for our patients. So today, I will introduce the intraoperative part about the Eras protocol in division of thoracic surgery. About the intraoperation, how we do it is an important thing. We need to know the Eras protocol. I choose the three main issues about this topic. The first one is localization for early stage lung cancer. The second is oral drainage omission after VATS. The third is low specific lymph nodes dissection. The first one is localization for early stage lung cancer. As we know, the famous national screening trial of the United States, lung cancer screening trial of the United States, and published the outcome in NGN in 2010. Yeah, we know 2012, yeah, we learned a lot of screening trial from screening strategy from this trial, and we find local CT is a pretty good tool for our patients to perform the screening for high-risk patients. After the local CT, we could find several tiny nodules, ground-based opacity nodule, or partial solid ground-based opacity nodule. How we perform operations smoothly? We need to perform the localization first. Before local CT and before we have hybrid OR, we adapt the method use two-step localization. The two-step localization of lung nodule, which means we send our patient to our radiology department, and then after the localization, we send the patients back to the general ward and pending, maybe 20 minutes, maybe 30 minutes, maybe 1 more hour. It will increase the risk of time of exposure. So currently in our hospital, we adapt the one-stage CT guide localization for tiny nodules. One stage, which means the general anesthesia patient was put on the table and put in a decubitus position. And then we use the real-time CT with a high resolution. And we could find the tiny nodule or GGO. And then we perform localization. And then after localization, we perform the operation, the surgical resection of the nodule, which includes there are several advantages of this procedure. And we make the statistic about our preliminary outcome and published in the SCI paper journal. We divided our patient into two groups. The first one is one stage, another one is two stage CT guide localization. You could find we use a graph to localize the lesion and then perform the transthoracic localization within the hybrid OR. We don't need to send the patient to the ward and then to the operation room, and the patient was under less exposure time about the risk. After we scanning of by the CT scan, we perform the localization. This is a CT image of one of our patients. You could find we use the graph to localize, and we could find and localize the tiny nodule precision and accurate. And then we use a two-step localization. The first is we inject ICG to localize this lesion in our surface of the lung, and then we don't know the depth of the lesion, so we use a wire to localize, and we could easily know the depth of the lesion. So we use ICG first and insert the hook wire later. About the two groups, the basic characteristic of the study did not have a significant difference. About the operative and the perioperative variables and the time variables, the most important is the time variables. You could find the time at risk decreased significantly compared with two-stage CT guide localization. So currently, we use a one-stage CT guide localization in our hybrid OR and bring the advantage for our patients. It does match the spirit of Eras. After the localization, we perform the resection. This is the first part, how we improve our Eras. The second part is pleural drainage omission after thoracic scopic sublobar resection. As we know, after tiny nodule or the ground base opacity, is a lobectomy necessary? No. Currently, according to the literature review, we could perform the sublobar resection, which include matrix section and the segmented bone. Sometimes we apply the single bone, and we only need one incision about 2 to 3 centimeters to perform operation. After operation, we close it layer by layer, and finally we apply the glue. So patient back to work or back to their home, they could take a shower and don't need to change dress. There are several advantages about the we did not place the drainage tube. Okay, we still have a preliminary outcome about 2 groups patient, which include one group with postoperatively we put the drainage tube, and the other group is a drainage group. The basic baseline characteristic about these 2 groups did not have any difference. And of course, there are some different law and different surgical approach. Yeah. It could be performed in different loads, no matter right up low, middle low, low low, or left up low and the left low low. We all could choose the tubeless method for our patient. About the postoperative complications and the surgical outcome, this is our endpoint, the most important part. We could find if we adapt the tubeless method, which means we cannot put the pigtail or chest tube after operation. The patient's the length of stay increase obviously. And the thoracic drainage duration, of course, because one did not put the chest tube. So, the most important thing, we could shorten the length of stay, and it reached the statistic significance. The third part is lobe specific lymph node dissection. The main idea is from Japanese doctor. They choose stage 1 and 2 non-small cell cancer patient to include into their multi-center study using the propensity score to analysis, and which gets a pretty good outcome. So they involved in a JCAR 13 phase 3 trial of node specific lymph node dissection compared to systematic nodal dissection, which means they choose a low specific lymph node dissection. They does a less lymph node dissection compared with a systematic nodal dissection. About the systematic nodal dissection, our cancer, about stage 1 or stage 2, basically we will adapt maybe more than 3 stations, maybe more than 15 nodals to dissect. However, about the node-specific dissection, we don't need to take so many lymph nodes. Of course, we will care about surgical outcome and outcome. So, as mentioned above, in our division of thoracic surgery, we take statistics and to check our outcome between these 2 group patients. So this is a published patient study about the comparison of outcome between systematic lymph node dissection and the lobe specific lymph node dissection in stage 1 non-small cell lung cancer. We divided into 2 groups. One is performed the lobe specific dissection, another did not form lobe specific. We take the systematic, take much more lymph nodes compared with lobe specific lymph node dissection. About the upper lobe, we will take stage 2 and 4 about the right upper lobe. About left upper lobe, we will take station 5 and 6 lymph nodes. About the right lower lobe, we will take 7, 8, and 9, station 7, 8, and 9. How about the nodal harvest status? We could find about the number of nodal number we harvest. It did not reach a statistic significance. So if we adapt the low-dose, low-specific lymph node dissection, how about the overall survival, about the surgical outcome, and the oncological outcome? We could find about these two groups that did not reach the statistic difference. So we think the low-specific lymph node dissection would be a feasible method for our patients with stage 1 lung cancer patients. About the conclusion, the implementation of Eras protocol for surgical patients is necessary. Quote my favorite basketball player, Kobe Bryant, his words, his sentence. He said, if we want to make a progression, we would not expect the quantum leap, which means we from bottom land and just a quantum leap to the top of the evidence. It's incredible, and it's if we want to make a progression, we need to step by step, 1 foot in front of the other. So currently, we will expand our expertise in precision lung cancer surgery, and be open-minded and keep going. This is our my speech. Thank you so much.
Thank you, Mr. Chen Yanqiang.
Okay. Thank you.
Let's move on the program next. I would like to invite Dr. Chen Yuxun. His topic is on Eras for colon surgery.
Hello, Professor Chin and everyone in the University Hospital. I'm Dr. Chen Yuxun, and I'm a colorectal surgeon. And I'm glad to be here to share our experience introducing Eras protocol into colorectal surgery in our hospital. And this is my outline today. And I will introduce the concept of Eras briefly at the first, and then to show you our protocol setting of colorectal surgery, and I will give some conclusion of our experience to of introducing the Eras protocol. Okay, as all you know, the concept of Eras are first introduced in 1994, and the name of that time is called fast track surgery, and Dr. Henry applied this concept into colorectal surgery in 1999 and had a significant outcome to shortening the length of stay. And the Eras study group was established in early 2000, and the Eras Society was founded in 2010 and continue growing up until today. And the main concept of Eras, as all you know, is to keep the health condition of patient even after the surgery, and by prepare the patient before the surgery, such as doing nutrition supplements or the physical training. And it could reduce, some not post-operative pain, nausea, vomiting by 50%, and reduce the length of stay by 2 days. This and even the tiredness could reduce about 20% after the surgery. And all the elements of the Eras protocol are contributed to 4 or 5 parts, including the pre-admission part and the pre-operative and intraoperative and post-operative, and even the post-discharge follow-up has elements of Eras protocol. And as the recent studies showed, they suggest that if we can complete over 70% or even more items, we can complete those items of the guideline, and we can have the marked reducing or marked reduce of the post-operative complications. So it was suggested by the Eras Society that we have to have the compliance of all the guideline items about above the 70%. And as the benefits of introduced Eras into our daily practice might have reduced about 30% of length of day and about 50% of complications, and even have 17% of medical costs related to surgery reduced. Okay, I will introduce our protocol setting in our hospital for colorectal surgery. And I will divide it into two parts. One is pre-admission and after discharge follow-up, and one is perioperative period setting. I'll first talk about the perioperative period. And I won't stress much about the surgery because all you know more than me for the minimal invasive surgery and the anesthesiologist. So I will talk about the preoperative setting and postoperative setting. The most item I list here is followed just by a guideline suggested by the Eras Society. As you see here, the orange letters here, like this one and this part, is a little bit different from the guideline because we don't have much confidence to do that. As you see here, we still have bowel preparation before the operation because spillage during the operation is still bothersome to us. So the guidelines suggest that we don't have routine bowel preparation before the surgery, before elective colorectal surgery, but we didn't do this because just as I said, this fecal spillage problem is still bother to us, and we don't apply the high concentrated glucose water until 2 hours before the operation because it's a little bit inconvenient to do this because the first scheduled operation we will send patient into operation room before 7 a.m. So if we apply this to the first scheduled patient, then we must wake them up before the 5 a.m. I think it's not reasonable for us because they to interrupt their sleep. So I didn't apply this to our patients. And surgery, I think the key elements of Eras protocol is to do the minimal invasive surgery to the patient. I mean for the surgeons. And for the anesthesiologist, there are much more things to do during the operation, but I won't stress too much today. So I just bypass this part and I will talk about the first day after the surgery. We will we will let patients drink liquid diet, full liquid diet. We use the oral nutrition supplement for our patient and suggest them not to take about 500 milliliters per day at the first day after surgery, and then force them out of bed about 30 minutes per day, whole day. And on the day 2, as you see here, and we will increase the amount of oral intake up to 1,000 milliliters per day, and make them out of bed more active. And we will remove our folding tube on the second day of surgery is visible. We might keep fully into integration one more day if we do the low anterior resection for rectal cancer patients. And as you see here, we still put intra-abdominal drain until the day before discharge. As the suggestion of the Eras guideline, they said there is no need to routinely put the intra-abdominal drain after the surgery if you have confidence. But we didn't do that much, so we still have intra-abdominal drainage until the day before the discharge. Then our daily fluid will keep below the about 1,400 milliliter per day, and we will adjust the amount of intravenous fluid by their oral intake. And the combination of oral intake and intravenous fluid will up to 2,000 milliliter per day. And as you see here, we will give patients state dose of antipsychotic agents before and after the surgery, the first day after the surgery, to reduce the stimulation of the pain or others. And we suggest we just follow the guideline, and most of patients we will give the long-lasting NSAIDs, like the brain here is dynastic. We will give them about every 12 hours per day and for 3 days. Okay, and we won't place a nasogastric tube routinely. So we don't, the patient won't have NG tube after the surgery. Right after the surgery, we will remove that. Okay. This is our recovery setting during the admission. Okay, this is our educational sheet. And we will give this sheet to our patient at our clinic. If I will talk this day later. And on the sheet, we will teach them what to do after the surgery. Like day 1, they can drink folic and day 2, they can drink more, like that. Okay, I will go through into the pre-admission and after discharge follow-up setting here. And this is a flowchart of clinical assessment process in our hospital. As you see at the left side, at the clinic, the first diagnosis, and after discussing with patient, we confirm the surgery date, and we will refer our patient to the assessment, and we will make them to join our line accounts. Communicating the line, as you know, like WeChat or something, is a communicating platform that allows us to communicate on allow us to communicate. And our case manager will contact our patient and make an appointment to do all this anesthesiology assessment and nutritional assessment and rehabilitation assessment. Our case manager will make an appointment with our patients and do all these things at the same day. And the nutrition, our physical therapists will teach our patients at the clinic to how to breathe and how to wake up, or how to move or active after the surgery, like how to ambulate or how to get out of bed, like that. And they will conclude all the specialist's opinion and post on the line account and for patients. And patient also can check some video or educational sheets or FAQ sheets on our line account. And then after assessment, the patient will do all the rehabilitation or nutritional support like drink oral ONS or doing the trifle training if they have respiratory problem, or do some limb training if they have weak limb activities. And our case manager will follow their condition on the line account about with a few days interval until they admit for surgery. And after the surgery, after admission, we will our nutritionists and our physical therapists will come back and will recheck our patient's condition again before the surgery. And for some patients are not suitable for the Eras protocol, like they have severe heart failure, like they have only LVF only 30% or something else like that. We will exclude this kind of patients out of the Eras protocol because it's very difficult for them. Okay, this is an example for of our patient to go through all the assessment path. Like he will make we have the diagnosis and confirm the operation on December 5th at my clinic, and I will let them to join the line account here and contact our manager to make appointment of the assessment. And on the December 7th, they will do all the basic examination at about 8:30 to 9:30 at our outpatient building, and then done all the assessment until about 11. It takes about 2 to 3 hours to make all these things, including teaching how to do the breathe training or limb training. And then the patient will go back home and until the admission. Okay. All right, this is our line communication platform. We use the line official accounts to do this, and we have some brief educational sheets, and they can check all these items on the app. There's a cell phone, and every time. And even the video for respiratory training and limb training. Our physical therapists do the video for us and put on the line account. And we can do all the real-time response during the working hours. If our patient have some questions about how to training or I have some problems, like I don't know what to drink or I forgot how to do some exercise, then our manager will answer them or answer them on the account or just refer them to us for further detailed evaluation. Okay, this is a preliminary result at our hospital. It's a little bit awkward. Post-operative length of stay is much higher than previously because we got 2 leakage and 1 severe surgical site infection and 2 severe ileus after the surgery. So but you can see, as you can see, it's marked reduce the time to solid food and time to bowel movement. We can reduce the time just compared to the traditional way to do this. Okay. And I will give you 2 successful cases. First one is a 73-year-old female and with relatively healthy condition. He was admitted first in September 9th because the obstruction. And after discussing a few days discussing and supportive treatment, and we finally decided to perform the laparoscopic right hemicolectomy on September 14th. And her condition was recovered very well and discharged on the post-operative day 5. And her condition was still good until the 2 weeks after discharge. And as you see here, this this one is his aura intake amount. You can see the day one can took about 1,380 milliliter per day on the day after surgeries. And the case two is a colon cancer with ostomy patients. It's even more faster to discharge. It's a 75-year-old male and relatively healthy and have received diverting colostomy on July 30th, and he discharged on fourth day after surgery during that admission. And he readmitted for the radical surgery on September 20, and we performed the left hemicolectomy on September 22, and he discharged on the third day after surgery. And his funding is still good and not come back to our ER or readmit for other problem until October 3rd. All right, I will go into the conclusion. And this is our tips. I know you're experiencing one more than me, but it's my tips for the Eras protocol to just because the Eras Society had already set up a very constructive guideline for us. So just follow up the guideline and stick with it as possible. And all the items you can do complete more than 70. That is our goal. And so, and for the colorectal surgery, I think the most key part of the Eras protocol is to do the early feeding, this one. And I suggest that everyone first to introduce this to apply the Eras protocol. Do not be afraid of early feeding because it's well documented that it's not increased any post-operative complications like anastomosis leakage or any suicide infections. So just don't be afraid because it's really hard to convince the doctors or patients to transform their mind to accept this. This needs time to educate the patient. And I think if the surgeon can explain what we will do after the surgery, then the patient might have more higher acceptance of early feeding. This one, and the third tips is to cooperate with other specialists like anesthesiologists, nutritionists, or physical therapists, and all they can do is will help you to complete more items of your guideline. And then I think the final, the last one is we should build a good post-operative follow-up system. This is the most important part of our case manager to do, and it can reduce some unforeseeable problems because patient could ask some problems on our communicative platform after discharge, and you can detect some problems earlier before they come back to emergency room or come back to or have some serious complications. Sorry. And the last part is I think there are some difficulties to introduce this protocol to in our hospital because the first one is the pre-admission and discharge follow-up. The part is it's a little bit hard to integrate the pre-admission assessment, especially all nutritionists, physical therapists, and anesthesiologists, because our program is conducted by surgical department instead of anesthesiology department. So it's hard for us to integrate all this assessment together. And it's a little bit hard for us to make a one-step visit. You can see the previous example. We have to take our patient through 2 or 3 clinics visits to complete all these assessments. So it's a little bit difficult for us. And another one is to improve our case manager. We just recruit our case manager in this month. Just get our case manager this month. So we asked our nurse practitioner to do the case manager's job before we got our case manager. Okay, and the difficulty of the perioperative period items is the first, I think the most difficult is the concept acceptance, like early feeding, especially for the colorectal surgery. It might be difficult to convince your patient to accept this concept, or even the doctors. And the second one is there are some income, because we don't have a complete post-acute care systems. Like we do all the post-operative care at the same hospital, in the same hospital. So you can see we cannot reduce our length of stay easily, just like the studies in Western countries. They can just reduce the days to 2 or even 3 or even 2 days after surgery. They can discharge their patients, but we cannot do that because we don't have post-acute care hospital, chronic care hospital to take care of these patients. And I think the third one is it's relatively cheap medical cost in Taiwan, so the patient will not want to discharge before they feel good, very good. So many of our patients will still not willing to discharge on the 5th days, even they could tolerate our oral intake very well. They can eat 2,000 milliliter or gram per day and have have bowel movements and even walk very well, and they don't have any pain or something, but they just want to stay at hospital because they feel it's more comfortable for them to care. So, and the last one, I think the difficult is there is no strong financial motivation for doctors to put on this, to introduce this, because it's difficult to charge, to have extra charge on the patients, because it's very cheap medical cost of patient to receive a surgery. So it's hard for us to charge extra cost on them by just doing Eras protocol. And no money, then the staff won't have motivation to do all of these things. So these are, I think, the difficulty to introduce the Eras protocol in our hospital. Okay, that's all my speech, and thank you.
Thank you, Dr. Chen Yuxun. Now, my pleasure to invite Dr. Vũ Hoài Anh from Huế Center Hospital will have a presentation about Eras in gastrointestinal surgery from theory and practice at Huế Center Hospital Branch 2.
So hello everyone. I hope you can hear me better with my headphone now. So will I have to share my slide directly on my computer, or what to do? So, just a small question. Did you see my slide?
Yes, we can see your PPT. Yeah.
Okay, I will start now. So hello everybody. I'm a very young doctor, come from the Hue Central Hospital, but in the Brand 2. So just a little bit about our situation. Is the Hue is small town in the Vietnam city, Vietnam, in compared with the Hanoi city and Ho Chi Minh city. So our volume of patient is not too much. In the other hand, I'm in the Brand 2 in the countryside, so we have not too much volume of operation per year. It has caused many difficulty for implementation of the Eras protocol.
Nào nó rửa máy lạnh nó đòi mà.
So we all know that the goal of the Eras protocol is for we can have the early recovery for the patient, we can decrease the surgical and non-surgical complication, and we can shorten the hospital stay too. But the problem, if we stand on the surgeon,
Anh Phạm Đặng Tấn gì đấy tắt giúp em cái mic với ạ.
So on the point of view on the surgeon, we fear about the anastomotic leak. If we perform the fast track, we defeating the patient too soon. And with another discipline is with many fear about a lot of things. So in our department, we try to change in the middle of the years of 2021. So we applied the Eras protocol. We can say that the modified protocol for the more than 80 parotid gastrectomy and also more than 50 hemicolectomy right and left. And I just want to talk about the anterior section of the rectum, because in this one we don't have the ostomy, the protection. So we try to do the Eras because if we have also ileostomy, we don't have the problem with the early feeding for the patient. When I was in France, I saw that they have the big funding for the patient. So before the surgery, they provide immunology drinks for the supply to the patient. They give the patient also the nutrition supply with very high cost. And in our country, in our region, you know, like me, I earn only 500 USD per month, so it's not acceptable with this price. And also for my people, so they the taste of the medical product is not good, so they don't accept it. So what I did is I provided the patient to you this one, a mark, a national mark, and they have a taste. This one have a acceptable taste, and the patient can have it. And you know the price is acceptable, less than $1 per cup, and then they can have 2-3 cups per day. A little bit farther, then it's not like our system is not similar in Taiwan, I think, because the patient go directly in our department, and we have to perform all the exam, the scanner, the biopsy before the surgery, and the patient stay in the department. So we have a gap about 5-7 days to between the screening of the cancer to the decision making of the surgery. So between this time, we gave the patient this product to improve the general state and nutrition state of the patient. And for the preoperative care, despite we have many clinical recommendation that the patient can take the liquid drink up to 2 hours before the surgery. But I don't know what happened in the other hospital, but in our small hospital, the anesthetist, not everyone say okay with this. So they will fear about the reflux, the complication of the anesthesia. So sometimes the patient have to fasting 6 hours before the surgery. And another reason is about administrative reason. That maybe in the morning, we have a lot of patients to take care of. So all of my assistants have to do the prescription to take about 1-2 hours. So the delay is about 2 hours for the operation in the morning. What we try to do now is multidisciplinary protocol will be created soon. So I think I hope that we will solve this problem too. On the like a surgeon, what we change is we try to change. So before all the gastrectomies by the laparoscopic surgery, we perform an extracorporeal anastomosis. That's just one incision, but the patient can feel the pain also. And now we perform the intracorporeal anastomosis, will be better. But on the colectomy and the anterior resection of the rectum, so before we used systematically the abdominal drain and also the nasogastric tube, but now we no need to drain, and on the nasogastric tube we take it up in the recovery room. In our system, it's a very traditional system. I think the patient has to stay in the recovery room at least 1 day. It's very hard to perform an early mobilization for the patient because we have not too much people in the recovery room, just 2-3 nurses for more than 10 patients. So, and very hard to maintain the delicate balance at 0 also because the surgeon, like a surgeon, we don't have the road to do the prescription there. So what do we do? It's right that our team, the surgeon, we are overloaded by the other surgery, but we try to do that we perform the big surgery in the morning and this small surgery in the afternoon. In the gap between these two small surgery, we try to return in the recovery room, and we help the surgeon help the patient to move, to sit in the bed, and we don't let the patient always lying down in the bed. Yeah, it's maybe better than at the day 1 when the patient return in our department. We will explain how to help the patient to mobilize with the help of the patient family member. It's good, much more better. For the early feeding, we feed all the GI surgeon. So in the past, we give the oral intake for the patient. At the moment, the patient has already a bowel movement, but this were our number. So all of gastrectomy, a partial gastrectomy with a D2, a real D2 lymphadenectomy. We also have the flightus in the first day of the surgery, and also for the hemicolectomy and also for the rectum resection. So personally, I don't feel very feared about this. So what did I do? In the day 0 in the recovery room, I tried to give the patient a little bit, just some milliliter of the glucose liquid to stimulate the bowel movement, and day 1 the patient can have a sub water spirit, and up to day 3, day 2, day 3, more concentrated sub, more dense and conscious, and from day 4, depending on the patient adaptation, we can give a solid intake by the mouth. For if we talk about the pain control, so in more a lot of recommendations they don't really agree with the use of morphine, the opioid regimen for the patient after surgery. But I think one dose after the surgery is not a big deal. So if the patient have important pain, we can use as one dose. The non-steroid I don't want, I don't like very much because I have a very bad memory with this. When first one surgeon, he has an anastomotic leak after and deal with steroid, no steroid treatment. We have the paracetamol. We don't have a tablet, but we inject one dose of the lidocaine in the wound site. And we have here you can see we had just a limited result of the EVA score after surgery. And the day one, gastrectomy and colectomy, we have the 5 point. And the day three, day three is about 3 point. The patient, our patient at day 3 or day 2 or day 3, they can walk here already. So I think it's not too bad. And it is safe. So now we just applicated the fast track, our modified Eras on more than 80 gastrectomy, more than 50 hemicolectomy, but we have zero surgery complication, zero leakage. But for wound infection is still high, about 3%, with no readmission. So that's all of my sharing about my difficulty and my solution. So for this part, please tell us how to improve more and more. And for the team who have the same difficulty like us, please share with us your solution and adaptation for the area protocol. Thanks for listening.
Thank you, Dr. Vũ Hoài Anh. Now we have 5 minutes for a healthy break and come back later. Let's move on the program. Next, I would like to invite Ms. Wang Ruhui to share the experience on Eras nursing care for colon surgery. Please welcome.
Hello, everyone. My name is Wang Ruhui. I am the head nurse of colorectal surgery ward in my hospital. I'm happy to share with the colorectal surgery nursing care Eras. Colorectal surgery nursing care Eras is similar to general postoperative care. The essence of Eras is early eating, early mobilization, and the limited IV fluid administration. Drainage tube can be removed as early as feasible. Eat early. Eating early is one of the key aspects in Eras treatment. In traditional colorectal surgery, patients are required to fast for at least 8 hours before the procedure and must wait until their chest gets before being allowed to drink water post-operative. However, for patients undergoing Eras treatment, fasting for at least 8 hours before surgery is still necessary. Within 2 hours before surgery, they can consume high carbohydrate drink to reduce hunger and maintain normal blood sugar levels. Moreover, they can start drinking water once the events of anesthesia subside without needing to wait for the passage of gas. Self-based early eating. Move early. For surgical outbreak activity, early mobilization is important after surgery as it can prevent potential post-operative liver thrombosis, improve intestine mobility and separation, and reduce complications. Post-operative exercise: 1. Deep decreasing exercise. 2. Coughing exercise. 3. Turning over exercise. 4. Deep exercise. 5. Off-bed exercise at least 30 minutes per session once a day. Colorectal surgery health education. Pre-operative hour preparation. Stool should be clear once the preparation is finished. If not, speak to the covering physician for the next day. Continue drinking clear liquid as foreign until you go to sleep. This will keep you from becoming dehydrated. Do not eat or drink anything after midnight, including chewing gum or lozenges. Unclear liquid diet the day before surgery. For example, if you are scheduled for surgery on Wednesday, your last solid food will be before midnight on Monday, being a clear liquid diet on Tuesday. Post-operative pain management. Multiple model pain relief helps reduce the need for opinion analgesia. Post-op wound clear and the teaching on wound dressing changes. The time to restore the epidermal wound to the removable suture is usually about 2 weeks, during which the wounds will be kept clean and dry. Except for special conditions, you can usually take a shower 2 or 3 days after surgery. Recommendation for abdominal fluid use. It is generally recommended to continue using abdominal fluid for 1 to 3 months after surgery. For wounds caused by minimally invasive surgery, which are smaller, shorter-term use, such as 1 month, may be considered. However, if you discomfort persists during normal activities, it is recommended to continue using the abdominal fluid until the discomfort improves. Dietary guidelines. After discharge, it is generally advisable to gradually return to regular diet within 1 week without the need to maintain a low residual diet. However, our team recommends avoiding spiceful road fibers such as bamboo shoot, celery, and the hard-to-digest food such as glutinous rice until there is no discomfort. Our team suggests maintaining a small frequent meal pattern for at least 1 month. The during can be adjusted based on the condition of abdominal discomfort. Activity guidelines. Generally, after discharge, you can engage in overload strength activity such as walking and light forceful chores. However, it is advisable to wait for at least 4 weeks after surgery before engaging in activity like light inlet have adjusted or learning. There are no specific departing and traveling by transport after general abdominal surgery. However, it is generally recommended to wait until the wound stabilizes, usually about 2 weeks after suture removal, before consider air travel. If there is still discomfort from the wound after surgery, it is advisable to wait until the discomfort completely subsides before traveling. For long distance from overseas transportation, consider your wound condition and the accessibility of medical care to avoid being unable to handle emergency. Bowel movement issue. After returning to a regular diet, bowel habits gradually return to their original state. Before this, an increase in bowel movements up to 5 or more times a day, but rarely accompanied by severe abdominal discomfort, and the patient lose or urgent stool are normal. After rectal section surgery, depending on the extent of rectal removal, the frequency of bowel movements generally increase incrementally. Patients may experience leakage, urgent stool defect, telemus, or even defecation pain, known as low anterior section syndrome. Some patients can alleviate these symptoms through medication and training, and to control bowel movements to an average of 3 to 5 times a day, but rarely return to normal. 6.
Thank you, Ms. Wang Ruhui. Last presentation today, please welcome Dr. Lê Quang Anh Tuấn from University Medical Center Ho Chi Minh City will give a presentation about implementation of Eras at University Medical Center Ho Chi Minh City since 2020, experience over 5,100 cases. Please welcome Dr. Lê Quang Anh Tuấn.
Sorry, I'm sharing my system. I cannot share. Okay, nice. Okay, thank you. I'm sorry, just a few minutes to prepare my slide. Thank you very much. It is my pleasure to share our experience with you, our colleague in Vietnam and from Taiwan. I heard all of your experience and I'm very interested in your experience. And now I will share our experience in University Medical Center. University. Can you hear me well?
Yes, yes, we can hear you.
Okay. So my talk will be about implementation of Eras at UMC and a short introduction on our Eras in our department in pancreatical duodenectomy. So I will pass it fast because already mentioned in other previous lectures. I think that Eras is not so difficult, but it is difficult because we have to integrate into the system, which is a multidisciplinary team to cover all of the process of the patients from admission to discharge. And the benefit is very clear that we can reduce the length of stay and reduce the post-operative complications. And of course, the cost. And the Eras protocol should start from pre-hospital phase until post-discharge phase. This is very important because some of our colleagues think that we just do some of the steps that will be Eras. It's not enough. So, and also our experience is that audit is also very important to improve the quality of Eras activities. This is my presentation in the past. In 2014, we already decided to apply Eras into our hospital. But at that time, we failed because we are not, some specialty are not ready. We do not have enough staff for rehabilitation, where we do not have a good staff for of nutritionists, and we also have do not have the products of carbohydrate loading, and then after starting, we just stopped because we lack of manpower to do everything. So after a few years of preparation, we start again on 2019. The board of directors decide to deploy Eras program in the hospital, and in 2020, we established a team for implementation and supervision of Eras in our hospital, and I am the team leader. We include every chief of the department and many members of different specialties, include anesthesia, rehabilitation, nutrition into our team. And we start right at the 12 specialties. At the beginning, we start with 16 procedures. Nowadays, we have 25 procedures with a specific protocol. And all of the results are positive. I will show you later. But we have to overcome many difficulties, as you have shown in the previous lectures. And we organize many internal training courses. This is very important. I think at the beginning, training is important to make the team member accept the concept of Eras, especially the surgeons, the nurses, they have to change their routine habit when during the course of surgery. And this is our 12 specialties with specific procedures. Nowadays, we have 25 Eras protocol. One of our advantages is that we can integrate these protocol into our paperless EMR, which is easily recognized when you access to the patient's records. And this is our result, the number of the patient under Eras protocol in our hospital. And you can see it is constantly increased year by year. And until now, we have more than 5,100 cases of all specialties. And we have already 3 audits. At the last audit, we recognize that this is the length of hospital stay decrease by every procedure. This is very good. And decrease of hospital stay, of course, decrease in the cost of the surgery as well. And during our implementation and applying of Eras and explain the Eras protocol, we also have many difficulties. I think you can see here, most of the time is the manpower. That means the workload for the nurse, the workload for the rehab team, a nutritionist. So manpower is very important. Another thing we have to overcome is that facilities. I will show you later how we overcome the facilities during our activities. And of course, one important thing that we do not have any difficulties with the acceptance from the surgeons and the anesthetists, because I can see that even in Taiwan, you have difficulties, and Hue Central Hospital, you have difficulties of acceptance of some surgeons that they do not want to fit the patient early, or some anesthetists, they do not want the patient to have a feeding until 2 hours before surgery. This is in our hospital. This is widely accepted by all of the surgeons and all of the anesthetists right at the beginning. So this is one of our benefits when we do Eras protocol to many different procedures. And of course, at the beginning, another difficulties is the low compliance. At the beginning, not so many people will follow the Eras protocol, although we have already have a meeting and have a very detailed protocol for each procedure, and that's why we have to have a very good follow-up and audit to increase the compliance rate. I also have a poster presentation last year in Aspen Congress in Europe. During the implementation of Eras, we also have a lot of training for surgeons. This is my training for surgeons about Eras. They have to understand what is Eras, what is the benefits of applying Eras protocol to the patients. This is for the nurse training. This is for anesthetists. This is for rehab team. And also we have to prepare many documents for presentation to the patients, which is very clearly explain the disease and the procedure, also the communications rate to the patients. And this is the consultant's material for anesthetists. It is very easy to access and easy to understand to all of the patients. And of course, our rehab team is not enough. So we do group training before surgery. And this is very effective because group training is good to follow, and it's fun. Everyone can see that the others also easy to adapt to the activities. Instead of separate training, individual training, we do group training. And together with the Society of Nutrition, our society also established guidelines for nutrition for patients before surgery. This is also important because it is one important step for surgical patient. And I myself have this is a nutrition intervention before surgery, and we almost follow the guidelines of clinical nutrition for surgical patients of S-band. And this is assessment of nutrition for the patient before surgery. It is mandatory, and it is easily integrated into our EMR. If the patient have a high risk, the patient will be have a nutritionist evaluation and intervention. Of course, in our department, we do mostly minimal invasive surgery. This is for PD, and you can see we are doing totally laparoscopic PD. This is after resection of the proximal pancreas. This is a transection of the CBD. And we do intracorporeal anastomosis. This is another case. I think nowadays the laparoscopic surgery is as good as open surgery in terms of cancer treatment. But we can have a better outcome of minimal invasive surgery, like less pain, early recovery. Of course, laparoscopic surgery is recommended for all of Eras protocol. This is we need a small incision to remove the specimen, and this is our specimen. So for PD in our department, we follow strictly to the protocol from Eras Society, and you can see here even anti-thrombotic prophylaxis. It is mandatory in all of our patients who underwent who will undergo surgery. We have to have an assessment of deep vein thrombosis, and in our EMR we have a decision support system for the doctors. Is you can see if the patient have the risk of deep vein thrombosis, there will be this. They can create the plan for each individual patient. And if you want to modify, you can modify this recommendation. And this is also very important that we have to assess the risk of aspiration when we do early feeding, because if the patient have a delay as gastric emptying, it is very dangerous. The risk of aspiration is high. And if the patient have the risk of aspiration, we will have proper activities to prevent aspiration. And in our PD, we do epidural anesthesia in most of the patients. And after surgery, we do not use somatostatin. It is very common in all of the surgeons after pancreatic surgery that they use somatostatin, but nowadays we do not use anymore. We also remove the drain early when there is no pancreatic leak. Okay, I will show you. This is Eras protocol has been integrated in our EMR. When you open a patient record with which is under Eras protocol, you can see an announcement or a notice like this. And this is easily recognized in all of the patients under Eras protocol for a specific procedure. And this is our checklist. Pre-operation, during operation, yes. If you apply, do not apply, or not applicable. Carbohydrate loading is easily accepted in our hospital, and it is mandatory in our department. We have no difficulties with this issue. And if the patient have any malnutritional risk, we have a nutritionist that we evaluate and have a plan of nutrition intervention for the patient. This is intervention for nutrition in if the patient have any risk of malnutrition, and it is mandatory. You cannot do operation in these patients. And we do drainage of biliary drainage when the bilirubin level is high. After this, after you can see that after each case, we will have a checklist like this, so we can easily recognize the compliance rate of each procedure. They're very strict. Another problem is that in recovery room, we do rehabilitation very early, the first day in recovery room. And you can see this is a protocol. One of our staff of rehabilitation access the patient and do the rehab for the patient in the recovery room. And our the patient will stand up out of the bed more than 80% on the first day. Also, we in our department, we also do Eras for liver resection. And this is the result from our department when we apply Eras. You can see that the first year compliance rate is only more than half, but nowadays nearly 100% of the compliance. This is very, very good. And under the implementation of the Eras protocol into the EMR. This is our result in the first 65 lab PD. You can see the mean time of rehab before surgery is more than 3 days, and nutrition intervention is 40% of the patient. Carbohydrate loading and no long fasting 100%. Anti-DVT prophylaxis 100%. This is very, very strict and very good. Basic NG chip removal is early, and feeding is early from 1 to day 3 for PD. Of course, in the past, for PD, in the post-operative course, the feeding usually late after 5 to 7 days because there's a lot of anastomosis, and this is a pipettic surgery. The pain score is low, and most of the cases, more than 96%, we use only acetaminophen for pain relief. Our complication rate is reasonable and low. Only one reoperation and no mortality. Most of the complication will have percutaneous drainage. For conclusion, implementation of Eras is a patient-centered activity. This is very important. That means every specialty, every major procedure should follow Eras protocol. Nowadays, we have Eras protocol for emergency patients as well. And the progress of Eras implementation in UMC is at least 3 years now, more than 3 years now, and we do have a lot of barriers, but we have overcome all of these, and that require many flexible and specific strategy. And our conclusion is that implementation of Eras is possible and requires teamwork in the system. All this is very important to improve, and that's why in 2023 we successfully established the Vietnam Eras Society to apply Eras protocol Eras in every hospital in Vietnam. Thank you very much for your attention.
Thank you, Dr. Lê Quan Anh Tuấn, and I would like to invite Dr. Lê Quan Anh Tuấn as the Vice President of Eras Association of Vietnam to be a chair for discussion session. Please welcome.
Okay, thank you very much for all of your presentation, and it is very interesting to share experience and difficulties in every expertise in Vietnam and in Kaohsiung. And now discussion is open to everyone, so we can learn more, we can share more on our Eras activities. May I have any questions from the floor?
Yes. First, I introduce myself. I am a district surgeon in the Việt Đức Hospital. On Earth.
I'm sorry that I cannot hear you well.
Bị mất tiếng hả? Yeah. At first, I introduce myself. I am a digestive surgeon in the Việt Đức Hospital. As I think on of Earth, we know the important roles of Eras. I think I don't repeat it here. Eras, as we know, it's systems of a lot of procedure. In fact, I think the Eras was carried out a long time ago. Our professor, for example, Professor Vân, Professor Khoa, in intensive care in ICU, in digestive surgery, in applied Eras, I think 30 years or 40 years ago. For example, we have to prepare the patients carefully before the operation. Have to examine the patient, the nutrition status of the patient. After the operation, our professors in the obligate us to early feeding. So now the most important, now we have to systematize the on-the procedure in a system. It meant good cooperation in multidisciplinary, for example, surgeon, anesthetist, nurse, the rehabilitation specialist, etc. As we know, the Eras included three periods: pre-operation, during operation, and post-operation. I think at first, the period, we know you have to prepare the patient, but we have to face the same difficulties. I think to follow the guideline, we have to prepare 2 weeks. We have to do a lot of things. But in Vietnam, in Ho Chi Minh City or Hanoi or Vietnam Hospital, it's difficult to carry out all things for the patient in the 2 weeks. We already a lack of the bed. We have a bed to prepare the patient, but the patient, our outpatient, it is very, very difficult to carry out this. I think period, the second period, the anesthesia, the surgeon, we have to the choice, the suitable procedures for the patient, for each patient. I think it offers effectiveness, but the most important, the third period, for example, post-operation. I think that for all of the negative surgeon, early feeding, it is the fear the surgeon. Almost the surgeon, they are fear the early feeding. It's risk for the leakage anastomosis. I think now the almost of the surgeon they wait the pass of gas after they wait the time to refeeding. I think they have to change the conceptions of the surgeon. Now the second, the early movement. I think on most of the surgeon anesthesists, nurse, all think agree with the early rehabilitation. I think I thank all the speakers. They share the knowledge and experience of some center. So for us, I think there are two points important. It is systemized own procedure in they have to build a protocol, the support of what direction to build a protocol and build a teamwork to carry out it. The second, change the conception of surgeon, anesthetist, nurse to initiate education for us. Thank you.
Thank you very much for your comments. And in our experience, whenever you still fear of leakage because of early feeding, then you cannot do early feeding to all of the patients. So for more than 5,000 cases, we do not have any problems with early feeding. We do early feeding for gastrectomy, for colectomy, for pipedical duodenectomy, and all of the leakage rate is equal or lower than the group without Eras. So with the evidence from all of the work and our experience, I think it's easy to persuade the surgeons from many other hospitals in Vietnam that it is safe, because you can see on our series results. The second is that you mentioned that we do not have enough time for the patient after admission for nutritional intervention or physical activities for the patient rehab before surgery. So it depends on each individual patient, and usually we do that in the pre-admission period. not all of the patient have admission and have a surgery right after the day after admission. So sometimes the patient have to wait for 1 or 2 weeks for the surgery. So our rehab and nutrition intervention should be during that time. So we can learn more on our Kaohsiung colleague about this. I think you can, I invite you to talk about early feeding difficulties in Kaohsiung in GI surgery, and how you manage your patient that needs nutrition intervention or rehab before surgery. Any speakers from Kaohsiung Hospital can give your experience on these two issues?
Hello, I'm Dr. Chen Yuxin from Kaohsiung Veteran Hospital. And I want to echo Dr. Wang's opinion about the early feeding. I think it's initially it's really difficult to convince the patient to receive the concept of early feeding, I think. So the way I salute this problem is to educate your patient at clinic at the first time you confirm the operation. You can teach him to we will apply let you to bring a fluid like to do the early feed. You feed earlier after the surgery, and there are many studies about the leakage, the post-operative complications, and is not associated with early feeding. It's well documented in the past decades. There is the studies of early feeding could trace into 2010. There is a Cochrane meta-analysis have shown that there is no increase in leakage rate after early feeding. So you can do it more confidently. But it's really hard to convince your patient to accept this concept. I agree that. So you have to educate your patients before the surgery and even before the admission. That will help. That might be help to do the early feeding more smoothly. Yeah.
Thank you very much. And one of our experience is that if the patient have less pain, the patient have almost no pain, the patient can walk, then it's very easy for the patient to accept early feeding. If the patient cannot walk, if the patient cannot stand up, if the patient have a pain, the pain is moderate or severe, they will not eat. So that we have to recognize that because most of the case without pain and the patient can walk, very easy for the patient to accept early feeding. That is our whole experience, especially in our procedure. Pancreatical duodenectomy is very, I think, major surgery with a high risk of leakage. But we are very comfortable to feed the patient early. That's our experience. Thank you very much. So please, another question, please. We can share our experience on. Yes. This is very interesting to share our experience so that we can apply successfully Eras protocol to all of our patients. I would like to invite Dr. Vũ Hoài An. Please.
Yes, that's the question from Viet Hospital University side. Can you hear us?
Yes, please.
I'm the Chief Nursing Officer of Viedic Hospital. I have a question. Here in our room of Viedic Hospital, we have almost nurses. So we learn about the Eras for a long time. But now that we have a team to work together with the Kaohsiung UMC and Hue Center Hospital. So thank you very much for sharing all the experience and expertise and the result in applied the Eras. The problem is the nurse is the biggest population in the hospital to take care of the patient, right? But now in our setting, for example, even our clinical nurse, they recognize about the patient need early feeding. The patient needs to remove the urinary catheter or nasal tube. The nurse recognize that the patient can move or get out of the bed. But the problem is, if the nurse, we have autonomy to make the description, the nurse can do. But actually, the legal is the doctor prescribes for all those intervention. So now we debate several times that the nurse will learn, we have a knowledge. If have a specific guideline about criteria for remove the urine catheter, to remove the nasal tube, to prescribe or to allow the patient to stand up or to get out of bed or to do the exercise. But the nurse know, but they cannot do because that the guidelines they don't have. So if Kaohsiung or UMC or Hue, you have some experience, you can share about that so that we can build the good team. Thank you for some concern and question.
Thank you. May I invite Dr. Vũ Hoài Anh to share your experience in Hue Central Hospital?
Yes, thank you, Professor Lê Quang Tuấn. So I just want to share about our experience. It's right that we all know the nurse is will be take care of the patient after the surgery, is to make care of the patient, very close to the patient. But the medical decision making have to do by the surgeon. We all know. So what did I do? For the gastrectomy, we perform it in the morning, and in the afternoon we perform a little small surgery like cholecystectomy, like that, something like that. In the gap between two small surgery, I return into recovery room, just nearby the operation room. I will take out by myself the nasogastric tube if I see it's acceptable, and also the urinary catheter. I think if the anesthetist they don't need to, I take it out also. For the colectomy, in our team, the nasogastric tube is just for the anesthetist during the operation. Just after the surgery, it's me, the surgeon. I will take it out in the operation room. That's done. We don't need to wait to return into recovery room. So for another one problem is if we perform the anterior section, so that means we didn't touch, didn't go too deep to those, so that we don't have to fear about the complication with the ureter fistula. So I don't want to last the uterine catheter during the recovery room. I'll take it out. I will check it out. So it's not a problem. The decision have to be made by the surgeon. And if we have like the people, like a resource, so it's me, myself, I will do this in the recovery room. It's no problem. That's my experience. Thank you.
May I have experience from Kaohsiung team? Any problems with the nurse to remove the NG tube or the ureteral catheter, on the first day? You need the indications from the doctors, or it is from the protocol. You can automatically remove in the recovery room or when you transfer the patient to the surgical ward. Please, the nurse team in Kaohsiung. What is your experience? To remove the or NG in the patient surgical ward.
So sorry, can I respond?
Okay, sure. Absolutely.
I'm so sorry. We just we did not routinely place the nasogastric tube during the surgery unless the gastrin is full of gas. So it still depends on the surgeons, I think. So you have to educate your surgeons to accept this concept, to not routinely place the nasogastric tube during the operation unless there is some obstruction or something else. So we basically we didn't have any nasogastric tube insertion, even not during the operation. If we have to do this and we almost remove the nasogastric tube, just like the doctor just said, we just remove in the waiting the rest room. Yeah. Sorry, the recovery room. Sorry. Yeah, we just remove the nasogastric tube in recovery room and not bring back to the ordinary ward. And the Foley tube we usually remove on the first day of after the surgery if patient could walk to the bathroom, because some patients cannot avoiding on the bed. This some patients not used to it. So if they cannot get out of bed easily after the surgery, we might keep Foley indwelling until they can walk easily to the bathroom. Okay. That's our daily practice. And if the nurses are just follow the order of doctors, so I think the basic principle is doctor must have to have this concept to accept the early removal of drainage tubes. Yeah.
Thank you. In our experience is that any indication for removal of the NG tube and urethral tube should be from the doctors. But in our hospital, urethral catheter must be removed before 24 hours after surgery, except any specific condition. So that is a must. Before you transfer the patient to the surgical ward, an anesthetist have to give the order to remove the catheter at least right before you transfer the patient to the surgical ward. Secondly, we also usually do not put the NG tube anymore. No more NG tube, especially in specific condition. That means that we actually that is not our issue anymore in our team. NG tube, even gastrectomy, we do not do NG tube after surgery, most of the cases. So we do not have any problem with these. So NG tube, if it is still there, when back to the surgical ward, so the surgeon will be the one who decides to remove the NG tube. And most of these recommendations should be stated in the safety, I think the regulations of the safety in the OT, that when you remove the catheter NG tube should be given to the staff right after the surgery. I think it is recommended for all of the surgeons. So I think in the hospital you have some difficulties. You can have a team to visit the Huế Central Hospital or UMC, our hospital. We can share our experience easier, because actually these are not our problem anymore. Yeah, thank you.
Thank you very much for your valuable sharing. That we we will work with our team here that for the look like the invasive intervention like NTUs or the urinary catheter that must given by the doctor. And we should make the protocol, for example, for the first day, the maximum that 2 days, if have a very special need to remain it, we need, the doctor must note in the medical files. So in case for the nurses, we every day that two time to assess about those things. And then based on the normal or abnormal, the doctor makes the decision. I think that's a good experience from you. Thank you very much.
Thank you. Thank you for your comments. Any?
Okay, right now, Dr. Cheng, I have 3 questions to 3 speakers. Actually, I'm also a GI surgeon. I'm very interested in this topic as well. So it's my first question to Dr. Chen from the Kaohsiung Regional Hospital as well. So I think you have a very long journey to develop, also to implement such a ERAS, for the patient in your hospital as well. And I learned that you almost implement that for elderly patients, right? Something is it. But I think it's very important that have to change behavior, the culture, also the form, the concept, also people, they can accept, this one as well. It's my concern that, you mentioned about 2 or 3 weeks, right? 2 or 3 weeks before, the patient admitted to the hospital, that you give some, ERAS implementation. So it seemed to me almost, 3 weeks, before that the patient, they come for first examination, admission, also until they discharge as well. So it's even also very short, long stay, you mentioned, but for on procedure, it takes time, right? Very long. So how you can deal with that problem? And also for that education to the patient or the family when they come, for example, should be, it's a multidisciplinary team that are own specialty, surgeon, anesthesia, and also nurse, rehabilitation, pain control as well, something that they should come on together on, when the patient admitted, right? And Dr. Chen, you get my question. You get my question, right, Dr. Chen?
Sorry, your first question is how to because we just do all the exam before admission, not so 说后面的。Sorry, I will discuss it. I'm sorry. I'm sorry. Your first question is the clinical setting about how to do all the pre-admission procedure in 2 to 3 weeks, or is that your question? Sorry.
That's mean you give some, like education to the patient or the family, right, on ERAS implementation as well. So on the first, the examination, also before admission, something that you mentioned about 2 weeks or 3 weeks, something like that. And of course, including from, that the patients, they stay in the hospital for surgery until they discharge. It seems to me that almost, 3 weeks or maybe 1 month, right, from the first patient, they visit you until they discharge, right? It's a, even though right now you're very short, letting stay in the hospital, but for on procedure implement, it take time, it's very long.
No, sorry. We didn't admit our patient do not need to admission before the surgery. So the pre-admission phase will be done at clinic setting. You know what I mean? I mean, all the pre-operative survey will done at the clinical setting. No need to admission. That's our practice.
Thank you. So it's my next question, because you mentioned about a multidisciplinary right team or specialty, they come to get advice to the patient, also for the patient family on the, they come for first examination only when you make decision for surgery, right? How you can coordinate all the people at the same time, something is it?
Oh, well.
Yeah.
Because I didn't have too many patients at my service, so usually I will have about one case per week. So I can make appointment, not the schedule not so tightly. So and you have to communicate with patients about to wait until the surgery. I know some patient might be very maybe feel uncomfortable about delayed surgery, but you have to talk to you can educate him. We have to prepare yourself and for the surgery and have the better outcome. That's my help to the patient can wait until the surgery. Is that answer to your question? Sorry.
Okay, thank you very much. And let's make the question to Dr. Hoài Anh, come from Huế Central Hospital, second branch. You mentioned about anesthetic that pain control, right? So you had some like a morphine, also NSAID, paracetamol, also the local anesthesia like lidocaine or silocaine you use. So who can make decision like this, anesthesiologist or maybe surgeon? They check over the patient after surgery. And then you mentioned about protocol because you into your presentation, you mentioned about two kinds of, GI surgery. The first one is gastrectomy, second one for almost a colectomy, right? Something as it. So it's a fitting. You mentioned that for all kind of surgery or maybe different from the gastrectomy or colon surgery as well. Thank you, Dr. Hoài Anh.
Yeah, thank you for the question. So for the first question is about the pain control. So is in our system, in our department, in the branch 2 hospital, I don't know what is this word in the branch 1, because in branch 1 we have many team of surgery. So in branch 2 we had just one team for the GI surgery and also the pancreatic surgery. So it's me, the main surgeon. I will decide to use what we have to use like pain control. I don't want too much the non-steroid because I just said that I have a very bad memory. When we're in France, my professor, he had a fistula, a leakage of anastomos, and he said that this may be related with non-steroid, and also on the clinical trials, there's many research that study told that maybe he has had problem with this. And about the opioid use, I just want to use one dose if needed. If the patient, if the pain we were not well controlled by the paracetamol, so we can give just one dose after the surgery. That's enough. We don't use it all today because it will bear the return of the bowel movement. So I don't like to. For the second question, is the oral intake is different between the gastrectomy and the colectomy? I think it's in my presentation, in three first day, it's just about the liquid oral tech. So the drink in the day 1 and the day 0 in the night of the day 0. The day 1 is the sub, so very easy to take for the bone surgery. And the day 2, day 3 is also the porridge, but more concentrate is normal. And after that, so after day 4, we depending on the adaptation of the patient to decide what the patient can eat. Like we all know we have the anastomose on. So the regime is the regime low of fiber. That's all. Yeah. Thank you. So in this field, for the nutrition, for the regime after the oral intake after the surgery, I really want to know about the experience of the Dr. Lê Quang Anh Tuấn if we have to choose different type of the regimen after the gastrectomy and colectomy or not. Thank you.
Thank you, Dr. Hoài. Actually, you learned that you don't see the conflict, between anesthesia and surgeon as well during operation, also post-operation as well, something like that. So how to make, protocol, agreement for own party. And thank you very much for sharing experience from Central Hospital. I think you learn a lot from you as well. So how to implement that? First, develop that protocol for Việt University Hospital. And my last question, but shortly to Dr. Lê Tuấn, right? So I think also you have a lot of patients, almost, the 5,000 K, but between 20 and 23 and 24, you had more than 2,300 days, something like this. I think you mentioned about very long journey, right? From the first, 2014 until right now, you can implement Eras successfully for almost all kinds that are surgery in your hospital. So I think it's very important thing you mentioned about low comparison, and also for the shortage of the resort, something like that. So you had some plan for the next step, how to implement Eras again in the hospital successfully. And I think a very important thing that you get approved from the leader, director board, something like that. I think from 2019 until 2021, something that almost, the 6 or 7 months as well. And so I want to learn from you how you can, deal with your own administrative process, something like that, the form you submit, you propose to develop also protocol. That just my concern, that big concern also. Thank you, Dr. Tuấn Anh.
Thank you, Dr. Jin. Actually, Eras is apparently very good for the patients, and of course for the doctors as well, because the patient have a better outcome, less cost, and less complications, right? And the first step should be recognition of benefits of Eras in all of the staff. And our experience is this is a top-down activity. That means after conception, that there will be a decision from the director that we should apply Eras in our hospital. That is very important. It's not a discussion. Of course, we discussed previously, but after decision, you have to follow. That is important. There is almost no discussion, only discussion how to apply, not any discussion against the Eras because of lack of manpower, because of any difficulties. We have to agree that we should work together to overcome all of the difficulties to apply Eras to our patients, for the patient's benefits, for the surgeon's benefits, for the hospital benefits. That is very important. First, I think that is first step. You must have the decision of the director that this is the way to go. Then you have to have a board or a team that is specifically worked on this objective. It is applying Eras to procedures in the hospital. So they will include a multidisciplinary team, of course. And I think that is the most important step, the starting step before we do anything else. And in our hospital, it is well accepted by all of the surgeons, except some. Some never know anything about Eras, but we have to have some training, have to give them evidence, and then we have a decision from the director that Eras should be applied in our hospital. I think that is very important, because if there is any conflict or any discussion, any difficulties between the teams, it's very difficult, especially the anesthetists. So it is our benefits. We are lucky that from anesthetists, they are 100% agree that Eras is very good for the patient, and they have to follow every step. Like they do a lot of things, right? They have effective pain relief for the patient, anti-nausea, and of course fluid balance during surgery, effective local anesthesia. Like in open surgery, they have to do the tap lock or epidural anesthesia. So when you have an agreement, I think everything will be smooth. But it is difficult at the beginning, and you need some young surgeons to be the pioneer. Thank you. I have one question in Hue Central Hospital. I see that in my opinion that from your series, it seems not all of your procedure will follow Eras. Only your team, not all. So you should improve, because this is not one surgeon's work. This is a hospital work. So not only one team. So everyone have to follow. Of course, we have the same problem. You see that in our hospital, only 50% of PD have Eras under Eras protocol. So there is another team. So after 1 year, they have to follow. So the next step will be applied for every surgery, not only one working team. And you need the support from the director as well.
Yes, yes, thank you for the comment of the Dr. Legwan, because I know you know very well about my hospital. So I'm very young surgeon. So in the Hue Hospital Branch 2, I'm working with the Dr. Nguyễn Thanh Xuân, the vice director of the hospital. So it's very easy to apply something in the Branch 2. But in the Branch 1, it's a big hospital. There's very many difficulties, because we have 3-4 team for surgery. But I have to say that I think we have to do in the future. We have to perform in union, the staff to ask the director board that so we have to improve in the Eras protocol. That will be coming soon. I hope so. Thank you very much.
Yeah, we hope so. We hope that every patient in Vietnam will have a benefits from Eras activities of our hospitals. Dr. Chín, anh Chín ơi.
Tuấn vẫn là share mà, khi nào Tuấn vào kết thúc thì sẽ chuyển sang cái phần ấy thôi.
Any questions or comments? Any questions or comments from Taiwan? We are very impressive that you have a good application, especially very detailed for the nurse to follow. We have to learn, and we learn from you that we will integrate a system that we can connect the patient to the surgeon or to the hospital's team before admission and after admission. We also have our UMC Care. That's a software that each patient will install the software into a smartphone, and we can connect the patient. The patient can ask whenever it is necessary. This is a very effective way to improve Eras integration, Eras involvement of the patient, because the patient's involvement is very important. The patient understand why they should stand early, why they should have early feeding, and even after surgery, nutrition at home also very important. And there's really a nice communication system between the surgeon, between the patient and your staff. We really learn from that. We haven't got any activities about that, and of course in our facility we can do that. We will facilitate the communication system between the patient and the staff. Yep, please.
Oh, thanks, Dr. Lagon's comments. And we're still trying to use the communicating apps on the smartphone, and it's basically actually the patient it's more easier, like Dr. Lagon said, it's more easier to connect with patients before the admission and after the after discharge. So we're still on trying the function of these apps, because it's still some difficulty in afford complete information for patients by smartphones. So we still need some educational sheets or some FMQ sheets on the paper to the patient before the surgery. Cannot totally on smartphones. Oh, I said I think we still need to afford some information on the paper. Yeah, cannot totally on the smartphone, because because patient cannot get all this information very clearly just by the cell phone.
Okay, in our hospital, each patient will have an account to access the data of their own data from our system. It's like lab test results, any information for the patient can send by the software to the specific patient. And when the patient have a revisit, the software also notice the patient there is a revisit during that time. Or now the software can follow vital signs of the patient, is weight, blood pressure, and leukemia. Like it's something like that. We will integrate the communication system. That is very good. And we are doing paperless. Every document of the patient can access from that software. Yeah. Okay. Thank you.
Thank you.
Okay, if there is any no questions and comments, I would like to close the session, and I would like to invite Dr. Jin for the closing remarks.
Now for the closing remarks, I would like to invite Associate Professor Nguyễn Đức Chính, President of Eras Association of Vietnam, will give some words.
So I see that, you know, the 1 hour different right now, almost 12, you know, that noon in Kaohsiung, right? So make, you know, very tired, also a little bit hungry because almost 3 hours from morning until right now. Anyway, Dr. Tuấn, also Vice President of the Vietnam Eras Association, and now also on behalf of the Vietnam Association of Surgery and Endolateral Surgery, and Việt Đức University Hospital, would like to thank all your kind contribution and effort for today, you know, video conference as well. From the 5 presentation on speaker, both sides, Vietnam and Taiwan, you learn a lot, you know, how you can deal with some difficulty as well from beginning until, you know, we can implement the ERAS, you know, for all the sick patient as well successfully. So hopefully in the future, you still get the support also from Taiwan College, also from own college in home country, Vietnam, Ho Chi Minh City and Hue City as well, how to implement that ERAS in our country. I think you learn that, you know, from Vietnam ERAS Society that was established last year. And on behalf of the Dr. Tuấn, Vice President of the Vietnam Eras Society, we try to invite you and inform some for next, you know, to plan. You will organize, you know, the conference in Da Nang around, you know, September of this year. And hopefully you can invite some college from Taiwan, not only from Kaohsiung Veterans General Hospital, but another, you know, Veterans General Hospital in Taipei and Taichung. They come to share experience on that field as well. And for next, no, it's the conference of the Vietnam Society of Surgery and Laparoscopy by end of this year. Also, we had one section for this. You would like to invite on the team from your side, not only surgeon, nurse, but also like a rehabilitation, nutrition, especially and the people so ready to come to join and sharing the experience with us. And again, thank you very much for all the your help and also contribution for the success of this, the first video conference. So I think that's a very good beginning for this year also for our activity that Dr. Tuấn and I also we are happy, right, for that Vietnam Eras Society. And thank you all speaker, Dr. Hoài Anh and Dr. Tuấn, of course, for hard work and also contribute, you know, presentation today. Also 3 speakers from the Kaohsiung Veterans General Hospital. Also the 4 coordinators that Miss May see it like, you know, the people, they make bridge between both sides. And again, thank you so much and hope to see you soon for next time. Goodbye for now.
Thank you very much. Thank you, everyone. I hope to welcome you in Vietnam, in Da Nang, for the first meeting of Vietnam Society of Eras, and in November in Ho Chi Minh City for conference of Basel. Thank you very much.
Now for the closing remarks, I would like to invite Kaohsiung Veteran General Hospital, Mr. Zhou Xuezhi, Director of Nursing Department, will give some words.
Thank you for every professor, doctor, and Hannah's. It's very happy we in this seminar we also learn very much. So I say again, thank you, and we hope we can share another topic soon. Thank you.
So thank you everyone. Right now I would like to end our, you know, the video conference. Thank you. How Cecily Minh? How? Chai Xuan.
Bye bye.
Thank you.